All right, so as far as determining what a rhythm is, you should know the nomenclature that we're talking about when we're talking about these rhythms. Okay, so whenever we're talking about the rhythms, the first thing you need to know is their intrinsic rates. So the SA node or the atria are going to have the pacemaker cells, which are the SA node in that case, but the AV node or the AV junction has its own pacemaker cells, just as the ventricle has its own pacemaker cells. Now, each of these pacemaker cells wait on a signal to come from the level above it, right? So if we have the SA node here, should send the signal to the AV node, should send the signal to the ventricles, right? If the AV node doesn't get a signal in time, it's going to start going off at its own prescribed rates. Okay, those pacemaker cells are going to say, hey, something's going on with the SA node, we're going to start doing our own thing. The same thing's going to happen for the ventricles. If the ventricles don't get a signal from the AV node in time, they're going to start doing their own thing. So these rates here for the SA node or the atria are 60 to 100 beats per minute. The AV node is going to be 40 to 60 beats per minute. And the ventricles are going to be 20 to 40 beats per minute. Okay. And when we talk about rhythms, we're talking about where this is starting from. If the rhythm is starting from the SA node, okay, it's a sinus rhythm. Sinus. And we'll put up here where from, right? If it's coming from somewhere else in the atria, we're going to have an atrial rhythm. Okay. Now let's say it's starting from that AV junction. Okay. What do we have? We have a junctional rhythm. And finally, what happens if it's starting from the ventricles? We have a ventricular rhythm, right? Seems pretty cut and dry with that part. The next part is figuring out like how fast and what kind of beat are they doing, right? So how fast? So the first one, the very fastest one, is going to be tachycardia. And generally, this is a rate greater than 100 beats per minute. Okay. So if we hear ventricular tachycardia, that means we have a rhythm that is starting in the ventricles and going at a rate greater than generally about 100 beats per minute. Okay. The next one that's a step down from that is called an accelerated rhythm. Sorry for my handwriting here. And the accelerated rhythm is going to be a step down from the tachycardia and a step up from the next one, which is our escape rhythm. So it's an in between of these two. Okay. The escape rhythm is the intrinsic rate. All right. So if we say the junctional, right, had an intrinsic rate of 40 to 60 beats per minute, if we see a junctional rhythm happening, okay, and it's happening at a rate of say 50 beats per minute, it's within its intrinsic rate, it's an escape rhythm. If that rate was going at 80 beats per minute, because it's in between tachycardia greater than 100 and the escape rhythm at the intrinsic rate of 40 to 60, we have an accelerated junctional rhythm. Okay. More commonly, the one, especially if you work in the cath lab, you'll hear is an accelerated idioventricular rhythm or accelerated ventricular rhythm. Okay, and that's a ventricular focus, so it's starting from the ventricles at a rate greater than 40 beats per minute, but less than 100. We usually see this in reperfusion syndrome whenever we open up, say, an LAD, and all of a sudden the heart's able to beat, but the sinus node hasn't quite caught up to that, and the ventricles get all of this blood back to it, and they decide they want to party. So that's the point. We'll have a ventricular rhythm that's going at, say, like 50, 60 beats per minute. Okay. The last one down here is bradycardia. And as you see, these are all happening kind of a stepwise fashion. Last one is just less than the intrinsic rate. Okay? So if we hear sinus bradycardia, the intrinsic rate is 60 to 100 beats per minute. That means we have a focus coming from the SA node. It's starting at the SA node, but it's going less than 60 beats per minute. All right. So this right here, you just learned pretty much all the rhythms. There's a couple different ones. So there is weird stuff, right? So the first big one is fibrillation, right? So with fibrillation, because the signal's coming from literally everywhere, uh, you can't determine the rate, okay? So fibrillation, that means whatever part of that is just kind of freaking out, just doing random stuff. The only two this happens to is the atria and the ventricles. So we have atrial fibrillation, where the atria are just sending a whole bunch of signals. But again, it doesn't matter because even though there's 100 signals going this way, right? Eventually they get picked up by the AV node and everything should go normally after that. So that's our fibrillation. Okay. The other one is flutter. That can happen, again, this is with the atria. That's when you have a random focus that's generally not the SA node. It's going to be somewhere else in the atria. And this is where we get a shark tooth pattern. Okay. So fibrillation is going to have a random line like this. This has shark teeth, kind of like that. Nifty way to see this one. It's actually if you turn the EKG upside down. That's how you can usually see if there's any atrial flutter going on. And again, even though this signal is weird going from the atria, it's still going to the AV node, so it should carry normally past that. So the last one to talk about is a heart block. So a heart block itself, usually whenever we hear heart block, they're talking about an AV nodal block, or AV block is the more proper termage to use with that, just because you can also have a SA nodal block that is classified the same way, and we'll talk about those later. The important thing to remember is that while they do affect the rhythm, generally we're not referring to the entire rhythm just as a heart block, because you could still have a sinus rhythm with a second degree heart block. Okay, so whenever we're talking about rhythms, we want to talk about whatever the underlying rhythm is. So we're talking about where this signal is originating from, and then we can add on things from there. So this next part here, we're going to start expanding on it and doing these things called laddergrams. If you understand the conduction system and that nomenclature that we just used for talking about these rhythms, this should hopefully help bring things together and make you understand it significantly better as to what's going on. So whenever we do our laddergram, we have A for the atria, AV for the AV node, and then V for the ventricles. There's some proper ways to do this as far as symbols and stuff you use. I'm going to do this kind of abbreviated in a way just to teach you this, so this way you can help to understand what's going on at each point, but we're not going to get super anal about it, okay? So the first thing we're going to do is we're going to draw out our EKG up above, okay? And repolarize. All right, so whenever we do this, we'll start with our QRS. Okay, so we'll follow the QRS down. That's going to be for our ventricles going off. So if we drop this straight down, we can make two little dots. So now this is also a narrow QRS. If it is a narrow QRS, what has happened is both of these bundle branches have depolarized at the same time. The only way both of these bundle branches can depolarize at the same time is if this signal, okay, has come through the ventricles, has come from the AV node in the bundle of His. If this were a wide QRS, that means either one of the bundle branches depolarized on its own, or the ventricle itself has depolarized somewhere else. So at that point, the determining whether or not there's a bundle branch and everything, you have to figure that out to figure out if it came from the AV node. But if it's a narrow QRS, it simplifies things. It came from the AV node. So we'll do the same thing. We're going to drop this part here. So what I'm going to do is right from where the Q is, we'll do a little circle here. And we know it went from the AV node to the ventricles. The next part we'll look at, so we have a P wave. Remember, if we look at the P wave, okay, if it is upright, and we're figuring we're using lead 2 in this case, it's gone towards that positive, okay. If it was positive in AVR, it would have gone the opposite way. Because it's positive in lead 2 rather than negative, it's going this way. So it's coming from the SA node. Okay, so we know there's an atrial depolarization, but it's coming from the SA node here. Okay, and that's going to the AV node and to the ventricles and going down. So it went from the SA node here, right, is where it started. It went to the AV node, which hung onto it for a normal amount of time. That sent it to the ventricles through the bundle of His and the bundle branches, and then they depolarized through both bundle branches up through the ventricles like normal. This here is our sinus rhythm, right? Because it started from the sinus node and went through. Now, if we determine the rate at that point, okay, that's how we determine if this was sinus tachycardia, right? If the rate was greater than 100 beats per minute, like we talked about. Or if the rate is 70 beats per minute, then we have a normal sinus rhythm. If the rate was less than that 60, or that intrinsic rate for the SA node, we had a sinus bradycardia. So that's how we can hopefully start to understand how the EKG is tossing this signal down through. So let's try a couple more. So now let's keep taking this on, and we'll go to our next one. So let's do, we got a weird wave like this, and then it goes, repolarizes, it's got some weird stuff, and then it repolarizes, or depolarizes, repolarizes, and it's going through. Okay, so we'll do the same thing. So the first thing, whenever we do the lettergram, I also like to start with the QRS, usually, just because that figures out whether or not we have any AV node and everything. So we see we have a narrow QRS. So narrow QRS means that it has to go through the bundle His, bundle branches. So we'll put a little dot here below our QRS. And since it's narrow, we know it went to the AV node at some point. Right? We can't clearly see that because there's no flat line here, but we do know it somehow went from the AV node to the ventricles. Okay, so this part has happened. Now what's going on here? We have these random wavy lines. Okay, so there's some kind of atrial depolarization stuff going on, and it's just random signals basically coming from all directions. There's no discernible P wave. Okay, and the reason there's no discernible P wave is because this is coming from everywhere. Okay, so if we draw this over here, if we're going back, the ventricles have depolarized like normal. Okay, and we know that came from the AV node. Okay, but now when we got to the AV node, there's some kind of dysfunction here. So the SA node isn't where this is coming from. It's coming from here, it's coming from here, it's coming from here, it's coming from everywhere. Because what we have going on is fibrillation in the atria, right? So we have a bunch of signals coming from all over in the atria going to the AV node. And that's what's finally triggering the AV node to go and send that signal down. So now this is coming from the atria to the AV node, but it's not coming from the SA node. So this is atrial fibrillation. Okay. So this is how we can kind of start breaking this down using these lettergrams and the EKG to figure out what is the source of our rhythm and what exactly is the rhythm that we have going on. So let's try another one. Okay. So we'll have a little break, and we'll have that. Right, so we have our QRS, and then there's a little random dip here, and then it repolarizes, and it goes to the next one, and it does the same thing. Random little dip, and then that. So we'll do the same thing. We'll start with the QRS. We drop that down. We see that there's the ventricles are depolarizing here, so there's our QRS. It is a narrow QRS again, so that means it is coming from the AV node, okay, to the ventricles. So we're backtracking here. The ventricles have depolarized like normal. It came from the AV node to do that. Okay, so we know so far it's come from there. But do we see a P wave? We don't see anything here. So nothing has actually triggered the junction to start this. We do have this weird thing over here, which is an upside down wave that would be small enough that it's coming from the atria, right? But it's not sinus, and it's going backwards. So what's happened is this is going this way, and this arrow is going this way. Okay. So the rhythm is starting at the AV node, or the junction. So this is a junctional rhythm. Okay, and what we're actually seeing here with this little upside down wave is if we were to draw out our axis, right? Normally the P wave would be this way because we're going towards the positive if this were over here, okay, for the SA node. Because we're going away from it, it's going opposite this way, like this. We have a retroactive P wave. So what's happened is the AV node is, or the junctional area has gone off, and that signal has backtracked into the atria to give us a P wave. But where it's arising from is still the junction. So this is a junctional rhythm. And again, we break it down just like we said before, depending on the rate. We have, if this were going at 50 beats per minute, this would be a junctional escape rhythm, right? If this were going at 120 beats per minute, we have a junctional tachycardia. If this were going at 80 beats per minute, so that in between, right, then we have an accelerated junctional rhythm. So this next one, okay, so we'll go, let's do this. Right, and we'll break this down again. So we can see our QRS, very big, right? We can break these down the whole way through. So these are quite large, but now here's the issue. They're wide QRSs, right? So are these coming from the AV node? Not particularly in this case. So this is one of those times we'd have to really get a 12 lead EKG to figure out what's going on. If we're just looking at this with one lead, you can't necessarily say if this came from the AV node or not, because as we talked about, the left bundle branch block or right bundle branch block before, or if they have like a paced rhythm or anything like that, that could make a wide QRS, right? But for the sake of this, it gets treated the same no matter what. We see a wide QRS, okay? The assumption is it didn't come from the AV node. There may or may not be something going on up here, but for all we know, the only thing that's going on is the ventricles are depolarizing themselves. So this is a ventricular rhythm. This would be called V-tach or ventricular tachycardia. Okay. There's a couple different variations of ventricular tachycardia. Uh, the two major branches that you'll talk about are monomorphic ventricular tachycardia, where each of these, pardon my drawing here, but look relatively the same. Or we could have something called polymorphic ventricular tachycardia, where they look different each time, right? So that's going to be an example like so, right? And this is changing each time. So this is a polymorphic ventricular tachycardia. The other one that's more commonly known, right, is it looks like a spindle. And this is still a polymorphic ventricular tachycardia, right? But you see this spinning the whole time. And if we draw this out, again, we're going to see the same thing down here where it's just the ventricles depolarizing themselves. But this does have a really unique shape. This one is still polymorphic ventricular tachycardia. The difference is going to be whether or not there was a prolonged QT interval before. If there was a prolonged QT interval, this is called torsades de poids, okay, or uh, some people pronounce it torsades de points because we speak English and not French. But that happens whenever there's a long QT and you have this waxing and waning of those QRSs. If you didn't have that abnormal QT interval, then it's just a polymorphic ventricular tachycardia. All right, and we'll do one last one here before we move on. Okay, so we'll draw this out like so, right? And then it depolarizes. We have a repolarization, and then it goes through. We got these random shapes, right? So it'll go the same way the whole way through. So we do the same thing. Start with the ventricles. We drop that down. Okay. So our ventricles are again depolarizing like normal. Because of that, we also know the AV node here is starting the signal. Okay. So the AV node has brought that to the ventricles. The ventricles gone through and contracted like normal. But then we got these random shapes up here. Now these aren't normal P wave shapes, so these aren't sinus. Okay. they're not sinus, but they are coming from the atria. They are smaller than their QRSs, and they're regular. So we're going to draw just an open circle like this here, and like that. And eventually what happens is one of these goes through, and it drops into this. So we have this one here, and then it drops. And there might even be one hidden in here occasionally, but for the sake of this, we're just going to use this. So we have atrial, atrial, and then one of them goes through to the AV node, and that kicks that down to the ventricles. This here, if we flip this upside down, or even just looking at this, it looks like shark teeth or shark fins. This is atrial, so we know it's starting at the atria. Flutter. And in this case, we would also describe it as 2 to 1 atrial flutter. Okay. And this is what's happening because we don't have that P wave. It's not starting from the SA node. There's somewhere else in the atria, say up over here. Okay. And that's sending this signal here at whatever rate. So since this is a 2 to 1, if we were to say this is the ventricles going off at 100 beats per minute, 200 times per minute, this spot here is sending a signal that way. And eventually it depolarizes the AV node enough that after it's hung on to that signal, it sends it down to the ventricles, and the ventricles contract. Okay. So this is, again, hopefully all those rhythms are starting to make a lot more sense. What you're seeing in the EKG can start making a bit more sense. And we can start looking at this more and more in depth now. So now, something we had touched on before, we're going to go in a little bit here, is our heart blocks. More specifically, whenever you hear heart block, okay, we're talking about AV nodal block. So our heart blocks. And we're talking about the AV node, okay. So we can have this same dysfunction here with the sinoatrial node, and it's classified the same way, but generally 90% of the time when you're hearing heart block, they're talking about the AV node and the AV nodal dysfunction. So this can happen because either the AV node isn't able to take the signal or it's hanging onto it for too long for whatever reason. Okay, so if we draw out our first kind of rhythm here, we'll do the laddergram here again, right? We see here that the AV node, the PR interval, okay, this is way, way too long. If we draw down, right, we'd have here, and then kind of eventually it's sent it down. We do have our SA node. So it is sent it down, but the AV node is hanging on to this for too long. But it does eventually send the signal. Okay, so this first one here is called our first degree heart block. Okay, first degree heart block or first degree AV block. All right. And that is when the PR interval is long, but they're still related. Okay, so the signal's being hung onto, and it's still being sent to the AV node, and the AV node is still sending it to the ventricles. It's just taking too long to do so. So this next one here is kind of the next step from that. Okay, if we did our laddergram again, we'd see here we do have that SA node is sending it, right? And this first one is being sent pretty normally. Then this next one here, okay, it's that same kind of issue we saw before, right? It's hanging on to it a long time, longer than it's supposed to. And then finally what happens is the SA node goes off, but there's no ventricular firing. Actually, it goes to the SA node again, and this would continue. So this is called our second degree. This is a type 1. Okay, second degree type 1 AV block, also called the Venki-Bach. Okay, so what's happening here is our AV node is getting the signal from the SA node. Okay, it's sending the signal, and initially it goes through just fine, right? But the AV node has probably become damaged, so it takes a little bit longer for it to repolarize and be ready for the next signal. And what happens is that signal comes earlier than it's ready, right? So it has to hang on to it for a little bit longer before it can send it out. Okay, and then finally what happens is it just gets overwhelmed. Okay, it's like you, whenever you're in, your undergraduate, that first time taking anatomy physiology, you can only take so much, and eventually you have that little break sometime around the midterm. So it doesn't send out that signal, and that's where it comes a breakdown. So the way to remember this one is that longer, longer, longer drop. It's a Venki-Bach. Okay, so that's when our PR intervals are going to continue elongating until there is a dropped QRS where it doesn't go through to the ventricles, and then the system restarts again. Okay, so this next one is kind of similar. Okay, so we're going to go through, trace these again. So we have the ventricles are going off. Okay, it's a narrow QRS, so it's coming from the AV node here. And then we'll go to our P's. So we have one here, we have one here, we have one here, and we have one here. And one of these is going through, right, for each of these, but the other one isn't. So what's happening is that this AV node has become diseased to the point it takes longer to recover. Okay, so in this case, this first signal, we'll use this one here, is going through, it's being conducted like normal. It's going from the SA node, going to the AV node, and the AV node is able to send this down to the ventricles, right? But what's happening is because it's fatigued, it takes longer to recover, right? So by the time it gets to this next signal, so the next time a signal goes through, so the SA node again says it's time to go, the AV node says, nah bro, we need to chill, okay? So he doesn't send the signal. He's not able to send the signal. So the AV node has a block at this point. So the way to remember this one, okay, is if some P's don't get through, you have a Mobitz 2, or you might hear, it's time to pace a Mobitz 2. And this is a second degree, okay, or Mobitz type 2 heart block. Okay. And this one in particular, because we have two P's for every R, is a 2-to-1 AV block. Okay, so there might be 3 P's, there might be 4, and you just add that on. So however many for each Q or S, or however many are not being conducted until one is. So this next one looks pretty weird, and we have to draw this all out again. So we're going to start with the P's. Okay, so you see a P here, P here, P here, P here, P here. All right, and there's a weird one that's tucked up in here, right? And you see this weird shape, right? That's unlike these other morphologies. So we can assume there's actually a P here, and there's another one that's buried up in here. And then we have the ventricles. Okay, so we have one here, we have one here, we have our QRSs there, and these are all wide. Okay, so this isn't coming from the AV node. This is themselves. Okay, and we can assume that these are going, but there's nothing going on there. There's a complete and total AV dissociation. The AV node in this case is completely not working. The SA node, okay, is just sending these signals, right, at its own rate. So that's these here. Because each of these, if we were to measure them out, right, we would say that each of these would have the same distance. So there would be an atrial rate of, we'll say, 150. Okay, but it's only related to itself. None of these, right, the PRs don't match up anywhere in here. And the ventricles, if we were to march them out, right, we'll say if they have a rate of, say, like 40, and they would be related only to each other. So there's no relation between the P's or the QRS's. So what's happening is the SA node is sending the signal, the AV node is not doing anything in this case. It is completely shut down. And because this is a wide QRS, the signal is coming from the ventricle's own pacemakers, okay? And they're kind of sending that up and around to themselves. So the ventricles are on their own, the atria are on their own. This is complete dissociation, or a complete heart block, okay? Also called a third degree AV block, or complete heart block. And the poem, again, the way to remember this one is if your P's and R's don't agree, you have yourself a third degree. Okay, so this can happen for multiple different reasons. Also, you could have a wide QRS, such as we have in here, where the ventricles are firing off, or if the block is towards the top portion of the AV node up in here, right, rather than the bottom portion, you could have a narrow QRS. So it's possible to have the AV node still sending these signals, right? And then at that point, instead of having this ventricular escape rhythm that we have going on down here, we would have a junctional rhythm, okay? But it still wouldn't be related to the sinus portion. So even though there could be a wide or narrow complex for the QRS, doesn't necessarily mean if there is or is not a heart block. That just means whether or not which portion of the AV node and the His-Purkinje system that block is happening in.